All right, well, welcome everybody to the fourth installment of our webinar series that we've done this calendar year. I'll go ahead and get started. I'm sure others will join the Zoom meeting here as we get started, but I'll just go through some initial information. First of all, thanks to Lindsay Carter, who's commented on the chat already. You can certainly put comments and questions there that I'll try and address at the end of the talk today. So again, for those of you who might be joining for the first time, my name is Avash Kalra. I am a transplant hepatologist at the University of Colorado, which is also where I trained. And I've been on faculty here a little over a year now. Today's topic is management of common hepatic decompensations, nuances, and updates. So we'll go ahead and get started. Just a little bit of housekeeping first. I've got no disclosures, nor do any of the planners, faculty, or individuals in control of the content today. Information regarding the evaluations is going to be sent out electronically. It is also on the website. Same with the information for obtaining AMA credit, either through here or through the nursing professional development as well. So the learning objectives today, we have a few. First, recognize that checking serum ammonia levels in patients with chronic liver disease is of limited benefit. Number two, appreciate the misunderstood coagulopathy of liver disease. Number three, recognize interventions for frailty in patients with chronic liver disease. And lastly, understand the application of liver transplantation for select cases of severe alcoholic hepatitis. Now, we've done a few webinars this year on various topics. All of those are available on the website, which I'll share at the end of the talk. But a lot of the topics today came from questions and comments from the earlier webinars, and we're going to certainly have another webinar series next year that I'll comment on later as well. So patients often ask, how bad is my cirrhosis, or what percentage of my liver has cirrhosis? The development of advanced fibrosis, including bridging fibrosis and then fibrotic nodules, occurs throughout the liver typically, no matter what the cause. And that when someone has cirrhosis, it's actually more helpful to think of them in two categories from a clinical standpoint: compensated or decompensated. And this is a conceptual framework of the stages of cirrhosis, 1 through 4. This isn't used universally, but it can at least be helpful to think about this question that patients will often ask: how bad is my cirrhosis? So the progression through the stages, namely the development of varices and ascites, is associated with significantly increased 1-year mortality. As you can see, a cirrhotic patient with no varices and no ascites has a 1% mortality at 1 year, compared to 57% for patients with bleeding varices with or without ascites. And this is based on a systematic review of about 118 studies from a study in 2006. So put another way, the 1 and 2 year survival for patients with decompensated cirrhosis is, as you'd expect, much lower. It's in the 50 to 60% range than patients with compensated cirrhosis, with survival rates over 90% for these endpoints. And then you stretch out this to 5 years, and the survival decreases quite notably for both compensated and decompensated patients with cirrhosis, as you can see in this graph as well. So what is the MELD score? So just because we may make references to this during the talk today, the model for end-stage liver disease score, adopted formally in 2002 as the foundation of the liver transplant waiting list. It initially was used and still is used to predict mortality following placement of a TIPS stent, so transjugular intrahepatic portosystemic shunt. It incorporates 4 variables: the serum creatinine, total bilirubin, INR, and serum sodium. So the MELD was actually incorporated serum sodium in 2016 after a large amount of data in the preceding decade that showed that the development of hyponatremia is a marker of increased waitlist mortality and neurologic dysfunction post-liver transplantation. So this is a famous graph showing the risk of mortality with an increasing MELD score. So the MELD score's predictive value has expanded to a variety of clinical scenarios since the MELD score was first developed, but its most useful and established use is to predict 3-month survival for patients awaiting liver transplantation. The MELD score range is 6 to 40, and the higher the MELD score, the higher the 3-month mortality. So it's at least 90%. When the mortality, is at least 90% when the patient has a MELD score of 40, compared to a 20% mortality when the patient has a MELD score of 26. And you can see that after a MELD of 25 to 26, about after that MELD score, as you increase a MELD over 25 to 26, that 3-month mortality risk increases significantly with each 1-point rise in the MELD score. A MELD score of 15 traditionally has been used as roughly the point at which the benefit of transplant outweighs the risk, as a patient with a MELD of 6, for example, is likely to have a higher risk of mortality with a transplant than when keeping their own liver. But the MELD score is not perfect and is not the only thing to consider. The MELD score has evolved in its calculation since its first use, and there are ongoing discussions on how to optimize use of this even further, since for a variety of populations, including women, the MELD score underestimates the severity of liver disease. For example, creatinine levels are on average lower in women than men, and that leads to a lower MELD score and therefore underestimates their disease severity. The other point I'll make here is that patients' clinical decompensations need to be factored in to the equation when thinking about whether or not somebody might need a liver transplant. The MELD score actually underestimates the risk of death in 25% of patients with moderate ascites. A patient with moderate ascites, as you can see in this graph here, with a MELD of 11 has an equivalent risk of death as a patient with no or small ascites and a MELD of 16. So therefore, the increased risk associated with moderate ascites can inform clinical decision-making and identify low MELD score patients who may benefit from liver transplant. Now, we see many patients in the hospital admitted with various clinical decompensations, and this is going to lead into the crux of the talk today. These decompensations that we see time and time again in our patient population. And these decompensations, too, are a significant marker of mortality. An inpatient database shown here of discharges from 2003 to 2010 in cirrhotic patients in Catalonia, Spain, found that in-hospital mortality for patients with ascites, for example, was approximately 9%. It was even higher for hepatic encephalopathy and higher still, as you would expect, for variceal bleeding and SBP, or spontaneous bacterial peritonitis. Hepatorenal syndrome, which is an end-stage condition that is a consequence of impaired blood flow to the kidneys due to cyclical physiologic alterations in advanced cirrhosis, is the highest in terms of inpatient mortality, as you can see, 60% in this database. So this emphasizes the importance of medical management of common hepatic decompensations. And I'm going to touch on nuances and some updates in management of some of the common decompensations that we see. So the remainder of the talk, we're going to discuss hepatic encephalopathy, ascites, frailty, and acute decompensation related to alcohol. This is, of course, just a small percentage of all of the medical management topics that we could possibly go over. We're not going to cover today, at least, variceal hemorrhage. We're not covering pulmonary complications of cirrhosis, such as hydrothorax, hepatopulmonary syndrome, and portopulmonary hypertension. And we're not going to cover cirrhosis-related malignancies, such as HCC. So first topic is hepatic encephalopathy. So a question, and if you were with us for the objectives earlier, I sort of clued you in as to what the answer is regardless. This is just something for you to reflect on as we talk about this. So serum ammonia levels, this is a common topic that comes up when thinking about managing patients with hepatic encephalopathy. So should serum ammonia levels be used to diagnose hepatic encephalopathy? Are they useful to titrate medications such as lactulose or rifaximin in patients with hepatic encephalopathy? Are they useful for prognosis in patients with hepatic encephalopathy? Or do they add no diagnostic or prognostic value for patients with HE and therefore shouldn't be used in management? So one of these is true, and we'll touch on which one that is in a little bit. So hepatic encephalopathy, just a broad overview to take a step back. I think many of you watching the webinar are familiar with this, but regardless, it's broadly defined as brain dysfunction, cognitive dysfunction caused by liver insufficiency and or portosystemic shunting. And it manifests as a wide spectrum of neurologic or psychiatric abnormalities, and that can range from subclinical alterations to a comatose state in the most severe grading of hepatic encephalopathy. Now, hepatic encephalopathy, or HE, is widely considered to be reversible following liver transplantation, but I do want to just mention that there are numerous studies that have demonstrated that there is a degree of neuroinflammation, neuronal cell death. These are features of patients who have overt HE episodes that can actually lead to some degree of irreversibility and persistent neurologic complications following liver transplantation. So we just have to keep that in mind, especially when patients have severe hepatic encephalopathy before a liver transplant, considering the possibility that there may be persistent neurologic deficits after transplant as well. Now, hepatic encephalopathy has traditionally been graded across a scale. Certainly, the Westhaven criteria can grade it from 0 to 4, but in addition, can grade it or classify it into two categories: overt hepatic encephalopathy, which is clinically manifested neurologic or psychiatric abnormalities, or minimal hepatic encephalopathy. So these are patients who may not have clinically detectable neurologic psychiatric abnormalities, but do have abnormalities on neuropsychologic or electrophysiological tests suggesting slowed or impaired cognitive function. Prevalence of overt hepatic encephalopathy, so at the time of diagnosis of cirrhosis, pretty common, 10 to 15%. In decompensated cirrhosis, even more common, up to 21%. And in patients who have had a TIPS inserted, up to 50% of patients have overt hepatic encephalopathy. And that's due to the portosystemic shunting that occurs as a consequence, an intended consequence, of course, of a TIPS. Prevalence of minimal hepatic encephalopathy is actually even higher. So patients with patients with cirrhosis have a prevalence rate up to 80% of minimal hepatic encephalopathy. Patients with a previous episode of overt HE have a 42% risk of recurrence at 1 year, and patients with recurrent overt HE have a 46% risk of another episode within 6 months, despite receiving standard care. So all this is to say this is very common, and if a patient has hepatic encephalopathy, they're likely to develop additional episodes going forward, despite our best efforts at treatment. This is just a slide that gives a little bit of an overview. This is from a review from 2020 of the pathophysiology of hepatic encephalopathy. So starting at the top, there are various systemic factors such as portosystemic shunting, malnutrition, electrolyte imbalances, potentially infections or bleeding that result in a variety of harmful pathophysiologic effects: inflammation, oxidative stress, and importantly, hyperammonemia. High ammonia is certainly a significant component to this and a contributor to development of hepatic encephalopathy. Ammonia crosses the blood-brain barrier, as you can see, and then that leads to the left side of the figure, leading to cerebral factors and alterations. So brain edema as a result of astrocytes, swelling and dysfunction, neuronal dysfunction, cell death, and ultimately the clinical manifestations of hepatic encephalopathy. So as I mentioned, ammonia remains at the core of hepatic encephalopathy pathogenesis. That's not really debatable, that it is a known neurotoxin that is not broken down in the setting of cirrhosis. So as you can see here, ammonia primarily produced in the gut as an end product of protein digestion, amino acid deamination, and bacterial urease activity. But in a healthy liver with an intact urea cycle regulates that concentration of ammonia and allows us to excrete it. Patients without intact liver function certainly are therefore at risk for poor clearance and potentially overproduction of ammonia, leading to those clinical consequences of hepatic encephalopathy. This is a broad overview in terms of diagnosis and management. What I want to point out really is step 2, ruling out other causes of neurologic and psychiatric disease. So like alcohol withdrawal, psychiatric diseases, drug overdose, and electrolyte abnormalities. Early management is really important, identifying precipitants, previous episodes, and an evaluation for infection is critical. Now, early management focuses on correcting the predisposing condition, such as infection, such as bleeding, such as perhaps not taking the medications used to treat hepatic encephalopathy, such as lactulose and rifaximin. And managing the predisposing condition will improve mental status in up to 80% of patients with hepatic encephalopathy. As I mentioned, in addition to infection, GI bleeding, and electrolyte abnormalities, constipation certainly would be another predisposing condition to this. To answer the original question, there's no role for checking a serum ammonia level in patients with chronic liver disease and hepatic encephalopathy. This is a, like I said, commonly discussed topic, but everything we've talked about until this point has focused on this concept that hepatic encephalopathy is a clinical diagnosis. There's no role for checking a serum ammonia level because it's not going to change management in any way. And this has been repeatedly shown in studies recently, relatively recently, 2 years ago now, American Journal of Gastroenterology, data published that, as you can see, it's all in the title. Ammonia levels do not guide clinical management of patients with hepatic encephalopathy caused by cirrhosis. So in that study, they had 1,200 patients with cirrhosis and a diagnosis of hepatic encephalopathy. And they drew ammonia levels in 46% of patients. 60% of the tested patients had elevated levels. And then the amount of lactulose was measured as well, given in the first 48 hours. It was actually similar in the tested and the untested group. And there was no correlation whatsoever between lactulose dose and ammonia level. So not only does it not help with diagnosis, but it does help with monitoring response to lactulose therapy either. Now, there is a role for checking ammonia levels. There's certain conditions outside the scope of today's talk that would result in non-cirrhotic hyperammonemia. An example of that might be a urea cycle enzyme deficiency or medications such as valproic acid that can produce ammonia. And in these non-cirrhotic cases of encephalopathy, checking an ammonia level may be appropriate if you're considering that on the differential. But in the setting of a chronic liver disease, there's no benefit. The best evidence related to liver disease is in terms of the prognostic role of ammonia and its relationship with severity of hepatic encephalopathy is observed in patients with acute liver failure. So again, a separate condition entirely from chronic liver disease. Acute liver failure would be a patient without known liver disease presenting with new liver injury, changes in mental status, and new coagulopathy. And in those patients, an ammonia level greater than 120 micromoles per liter identifies patients at high risk of developing intracranial hypertension and cerebral edema, which is important in terms of the critical care management of those patients, especially if they are being evaluated urgently for transplant. But in patients with cirrhosis, although the level of ammonia does not follow the severity of HE, we do know that in patients who have had ammonia levels checked, severe HE is generally associated with higher ammonia levels. Again, underscoring that ammonia is central to pathophysiology, but there's no need to check it on lab work because it's not going to change your management. So we're going to switch to management of another decompensation, very common, ascites, and a couple of nuances that come up while we manage these patients. So a really common issue is, well, is there an INR cutoff for patients with cirrhosis undergoing a paracentesis? Should we cut off the INR at 1.5, 2, 2.5, 3, or is there perhaps no INR cutoff? And so the first question, when we're talking about management of ascites, certainly management includes dietary sodium restriction, diuretics, and if needed, paracentesis. And these patients often have a high INR. And so we're often asked by our colleagues, perhaps in interventional radiology, perhaps in the emergency room, or even just other physicians taking care of these patients in the hospital on the floor, is paracentesis safe with a high INR? So first of all, what is the data about safety of paracentesis? So 85% of ascites in the US, first of all, is related to cirrhosis. Certainly there are non-cirrhotic causes of ascites, and that's a topic perhaps for another day. 71% of these patients with cirrhosis who have ascites have an abnormal prothrombin time. But the important note to remember is that coagulation tests, such as the INR, don't accurately reflect risk of bleeding in cirrhotic patients. And that's due to balance deficiency in these patients of procoagulants and anticoagulants. And that makes sense. Procoagulants and anticoagulants are all made in the liver. And in the setting of liver synthetic dysfunction, you're going to have a balanced deficiency of all of them. For paracentesis, just generally speaking, serious complications are really unusual. They're less than 1 in 1,000. Now, I think that if you were to talk with someone who has done thousands of paracenteses, they may remember the 1 or 2 complications much more than the 999 successful paracenteses. And so there's sometimes an anecdotal bias that goes into the recommendation of having an INR cutoff. But there's no data-supported cutoff of coagulation parameters, and that's actually noted in liver guidelines, but also interventional radiology guidelines as well. So this leads to this topic that I'll call the misunderstood coagulopathy of liver disease. So first of all, what's the INR? We have to remember how it was created. So it's a ratio of the patient's PT, so prothrombin time, as compared to a laboratory normative PT value. It was designed as a method of monitoring individual patient responses to anticoagulation therapy with a vitamin K antagonist, such as warfarin. The liver, as I mentioned, is responsible for the synthesis of many of the procoagulant and anticoagulant proteins responsible for maintaining homeostasis. And in fact, in most cases, a rebalancing occurs, and the vast majority of chronic liver disease patients achieve a hemostatic equilibrium. So there's no data to support that an INR less than 1.5 is safe for a procedure, despite wide acceptance of a cutoff such as 1.5. In addition, prophylactic transfusions, so for example, if somebody is requiring an INR cutoff of less than 2 or less than 1.5, that patient may receive transfusions of blood products, such as fresh frozen plasma, for example, to reduce the INR. But prophylactic transfusions expose the patients to increased risk of adverse events. So transfusion reactions, such as TRALI or transfusion-related acute lung injury, can exacerbate portal hypertension as a result of the transfusion, and really doesn't provide any protective effect for the reasons that I've already mentioned. I'll also note that despite this sort of false notion of what I'll call auto anticoagulation, meaning patients have a high INR, and so they must be anticoagulated. Well, that is true if you're on warfarin, but it's not true if you have cirrhosis. So the patients with hepatic dysfunction who have a high INR are not protected against the occurrence of venous thromboembolism or other thrombotic events merely by the presence of that elevated PT and INR. I think we all know this because we see these patients develop blood clots, DVTs, portal vein thrombosis, despite the high INR, despite that auto anticoagulation. The bleeding risk, I'll just note here, in patients with cirrhosis, we always worry about the bleeding risk in terms of portal hypertensive gastrointestinal bleeding, such as variceal hemorrhage. Well, that's related to portal hypertension, and that's a separate entity, separate pathophysiology than simply having a high INR. So additional nuances that I'll touch on briefly, the topics that come up frequently related to ascites, refractory ascites. What does that mean? Umbilical hernias, how do we manage those? And then other nuances related to procedural bleeding risks. So are there other tests of hemostasis that we should consider? And a little bit more on the risks of blood product utilization. So just a slide on refractory ascites. The AASLD, which is the American Association for Study of Liver Disease, has great practice guidelines on their website. The guidelines for ascites were updated last year, and this is a slide that essentially reviews what refractory ascites is. So large ascites while on diuretics, and despite diuretic therapy, continuing to have ascites. So first of all, how do we approach this? So we assess for diuretic response and complications. Sometimes you can check a urine sodium measurement as well in these patients, so that the urine sodium should be low in patients who are taking their diuretics and also adhering to a low sodium diet, less than 2,000 milligrams per day. And along those same lines, of course, dietary history to assess for that sodium restriction. If despite maximum doses of diuretics, despite documented minimum urinary sodium excretion, and in patients who are compliant with sodium restriction, we call that refractory ascites. And in those cases, the guidelines now actually do sort of formalize this recommendation to ensure that you're giving albumin with large volume paracentesis. So typically 6 to 8 grams of albumin per liter of fluid removed. I think a typical example of this would be if someone has 5 liters of ascites removed, they should get 50 grams of albumin. This is for every paracentesis, whether you have SBP or not, and is a sort of common misstep that I think we might see in patients who are undergoing regular large volume paracentesis. It's extremely important to give them albumin for a variety of reasons. One simply is for renal protection in the setting of large fluid shifts when you're taking out, say, 8 or 10 liters. You want to monitor these patients for for circulatory dysfunction related to giving them large amounts of albumin. There's been some data over the last couple of years showing that, for example, targeting an albumin level of 3.5 arbitrarily is harmful and not needed. As long as there's no other indication of giving albumin, we shouldn't be giving it. And then if patients continue to have liver dysfunction with refractory ascites, it's important to consider either TIPS or liver transplantation, and certainly consultation with a transplant center is appropriate in that setting. Umbilical hernias. So abdominal wall and inguinal hernias are very common in patients with cirrhosis and ascites. A lot of us who manage patients with liver disease see this commonly. Umbilical hernias develop in about 20% of patients with cirrhosis. And this is related to increased abdominal pressure from ascites, weakened abdominal muscles, certainly poor nutrition as well. These are factors that are associated with rapidly enlarging hernias. Patients who are candidates for liver transplant in the near future should defer hernia repair until during or after transplant. Patients will often come to clinic with decompensated cirrhosis, encephalopathy, varices, ascites, and their main complaint will be their hernia and asking to repair it, even if it's not really causing any problems. Sometimes it's related to cosmetic concerns, for example. But those patients who are potentially candidates for transplant, like I said, should defer hernia repair. And that's simply related to the risk of undergoing abdominal surgery in the setting of decompensated cirrhosis. The risks of hepatic decompensation and death are high. Now, if transplantation is not imminent, so a low MELD patient, so perhaps their MELD is less than 15, just as an example, elective hernia repair may be offered in those select patients after careful consideration of the risks and benefits compared to non-operative management. So again, if the patient has had recurrent episodes of incarceration of their hernia, perhaps the benefit is higher than the risk. If they have no problems with it other than cosmetic concerns, the risks are likely higher than the benefit. The use of prosthetic mesh, which is a common method for repairing umbilical hernias, may reduce the recurrence rates, but does increase the risk of infections and other complications. And it's typically, we would typically advise against using mesh to repair these. Now, emergent surgery is a separate topic entirely. So for example, for a strangulated or a ruptured umbilical hernia, so some of these patients are at risk for rupture of their umbilical hernia, in which case ascites fluid can leak out sometimes quite dramatically from the defect in the skin at the site of rupture. It's actually a condition called flood syndrome, appropriately named because of the what occurs in terms of leakage of ascites is actually named after a physician named Dr. Flood. Regardless, in patients with cirrhosis and refractory ascites who require emergent surgery in those situations, we really advocate that that would be best performed by a surgeon who's experienced in the care of patients with cirrhosis and portal hypertension, typically a liver transplant surgeon, for example. So now kind of going back a little bit to the procedural bleeding risk topic. So the use of fresh frozen plasma to correct a prolonged INR in cirrhosis does not actually change thrombin production, which is factor 2, but it does exacerbate portal hypertension. Now, there are these other global tests of clot formation. So I think the one that we're mostly familiar with is called a TEG test or TEG scan. It's a thromboelastography, which globally tests the components of clot formation to perhaps target which step in that mechanism is defective in these patients and may inform which types of blood products, therefore, that they may benefit from. This may eventually have a role in the evaluation of clotting in patients with cirrhosis. It currently lacks validated target levels. Certainly TEG scans are commonly used, especially in trauma, but haven't been well studied in cirrhosis. I think a lot of us are starting to use this regardless because we know that it's probably better than the INR, but we have to keep in mind that the target levels or the normal values of a TEG are not validated for patients with cirrhosis, and so we have to keep that in mind. And as I mentioned earlier, there's a real risk in exacerbating portal hypertension. If somebody has a variceal hemorrhage and their INR is 1.8 or 2, there's no need to give fresh frozen plasma to lower the INR in that setting. There's such large plasma volume, which is actually going to increase portal pressures and flow to those varices that are bleeding and therefore worsen the bleeding, that there's no benefit to doing that. And then immunologically, there's transfusion-related lung injury, as I mentioned earlier, higher when using platelets or plasma-containing blood products. And these patients develop HLA antibodies, and that can impact whether they're able to even get a transplant in the future in some cases, as well as impair their ability to receive further transfusions when they might actually benefit from them. Just a word on thrombopoietin agonists or TPO agonists. These are newer medications, now FDA approved, avatrombopag, lucitrombopag. They're oral thrombopoietin agonists that are approved for use in patients with liver disease, and typically are used to increase the platelet count before invasive procedures. Now, they can be used for a short duration in these patients to increase platelet counts to a safe level if needed, but it typically takes a few days, so it certainly isn't going to be used urgently. There is a risk of portal vein thrombosis in these patients that we need to be aware of, and I would not use these medications if someone has a known portal vein clot or a history of a portal vein thrombosis. Third decompensation we'll talk about today is frailty. So we've talked a little bit about hepatic encephalopathy, a little bit about ascites. Next is frailty. So again, as I mentioned, there's guidance from the AASLD in terms of management. This is one of their newest guidelines published last year: malnutrition, frailty, and sarcopenia in patients with cirrhosis. So cirrhosis is a catabolic chronic illness. We know that it's often accompanied by reduced appetite. These are factors that contribute to the poor nutrition in patients with advanced liver disease. We also know that malnutrition leads to poorer outcomes following liver transplant, such as with a BMI less than 18.5, actually has worse outcomes with transplant than patients with a high BMI over 40. And severity of muscle wasting can be masked in these patients because of ascites, obesity, but can be quite severe. There's a misconception regarding protein intake. I'll get this out of the way first. I think we know this at this point. However, in the past, there was historically a thought that limiting protein intake in these patients with chronic liver disease would be beneficial because of concerns that high protein intake may lead to increased ammonia production and therefore increased risk of hepatic encephalopathy. And while I certainly wouldn't advocate for these patients to have red meat 3 times a day, for example, limiting protein intake as a whole for patients with chronic liver disease would be harmful, just due to the risk of worsening muscle loss over time, and therefore increased frailty and the poor outcomes associated with that. So frailty is a sort of a global construct. It actually was developed in the medical literature essentially by geriatricians to refer to a variety of issues. So physical frailty, mental frailty. But in the setting of liver disease, frailty really refers to the manifestations of muscle loss and dysfunction. Okay. And so physical frailty is what this refers to. And it leads to a lot of important outcomes. So as you can see at the bottom of the slide, increased risk of decompensation, increased healthcare utilization, decreased health-related quality of life, death, and adverse post-transplant outcomes as well. So we define it as a clinical state of decreased reserve and ability to endure health stressors, such as the age-related cumulative decline of multiple organ systems. And as I mentioned, it's physical frailty, the manifestations of and consequences of the loss of muscle function. It's extremely prevalent. So in over 30% of patients listed for liver transplantation. And the concept of frailty has been the subject of a large amount of research over the last 10 to 15 years. In the past, we may have assessed frailty by the eyeball test. So walking into the room and looking at the patient sitting in a wheelchair and thinking, okay, well, that patient is frail. And it was very sort of binary. Now there's objective testing to measure this concept. And as a result of the objective testing, we've been able to study the link of frailty to outcomes. So increased waitlist mortality, decreased quality of life in patients awaiting liver transplantation, increased hospitalizations. Also worsens longitudinally without intervention and may persist even following liver transplant. It's been linked with mortality in the ambulatory setting, the acute care setting, the post-transplant setting. And the guidelines now from the ASLD note that all patients with cirrhosis should be assessed for frailty with a standardized tool, both at baseline and longitudinally. So we actually, at our center, use a frailty tool named the Liver Frailty Index. It was developed at UCSF. And it incorporates a small series of tests that are easily done in the clinic setting, such as hand grip strength and some balance testing, as well as their patient's gait. Frailty, as assessed by the Liver Frailty Index, or the LFI, is associated with a twofold increased risk of death in a study of over 1,000 ambulatory patients with cirrhosis awaiting liver transplant at 9 US centers. Now, why does frailty happen in these patients? So certainly malnutrition is part of this, impaired intake and uptake of macro and micronutrients. So these patients have reduced oral intake to begin with, related to symptoms and their disease process. They have malabsorption in some cases, such as patients with cholestatic liver disease, like PSC, primary sclerosing cholangitis. They have altered metabolic processes as well. So increased catabolism, increased breakdown of muscle tissue, for example. Cirrhosis itself causes it. So impaired hepatic ammonia clearance, which leads to mitochondrial oxidative dysfunction. That leads to myotoxic damage. Certainly systemic inflammation and endotoxemia contribute to this. Physical inactivity related to how sick these patients are, and social determinants of health as well. Patients who, for example, don't have caregivers who can promote physical activity and a good, healthy, high protein diet. These are factors that contribute to frailty in patients with decompensated cirrhosis. So how do we intervene? Well, importantly, we want to promote protein intake. So a protein intake of 1.2 to 1.5 grams per kilogram per day for adults with cirrhosis is the recommendation and really should be emphasized. I think that this is likely underemphasized clinically and should be part of our management of these patients in clinic, just like we manage their ascites and encephalopathy. We should be making sure we're telling our patients to increase their protein intake to this amount. Almost all patients are far beneath this goal. A protein intake of this level maintains a positive protein balance and importantly does not worsen hepatic encephalopathy, as I mentioned earlier. I'll also note that protein shakes, of which there are many brands, have a fair amount of protein in them. So in some cases, 20 to 30 grams of protein per shake that you can buy at a routine grocery store. And so I'll encourage patients to consume at least one of those per day, sometimes two, depending on the circumstances. Prolonged fasting should be avoided to limit exacerbation of that catabolism. So if we're fasting, we are in an increased catabolic state and may have increased muscle loss in that scenario. And so we don't want these patients to fast. And actually, evidence, therefore, supports having an early morning breakfast or a late evening high protein snack. This is more recent evidence that I think as hepatologists we're incorporating into our practice and recommendations to patients. Enteral supplementation should be considered too. So for example, via feeding tube, typically such as a nasogastric tube, should be considered particularly for patients awaiting liver transplant who have failed oral supplementation. And certainly physical activity is important as well. So it's not just diet, but these patients who are frail should create a physical activity plan in conjunction with their physicians and other providers, consisting of a combination of aerobic and resistance training for 150 minutes a week. This should obviously be tailored to the patient's baseline frailty and functional status, but this is a goal that we should try and achieve. Nowadays, we can also utilize modern technology, fitness trackers, smartphone applications to provide real-time objective tracking data and to identify areas for improvement. And so I'll often bring this up in clinic with patients who are maybe more tech savvy, or at least have support system, family members who may be able to help them out with this so that they can track their activity and even diet. The last topic I'll talk about today is alcoholic hepatitis. So management of this very, very common condition. So alcoholic hepatitis, before we get into this chart, I'll just try and define, what alcoholic hepatitis is. So severe liver injury, not typically related to chronic alcohol use. When I say chronic alcohol use, I don't mean decades of alcohol use. This is typically months to a few years of severe, sustained, heavy amounts of alcohol use that leads to a separate condition from decompensated cirrhosis. Certainly the two features could overlap, but this would be the younger patient, for example, who comes into the hospital with complaining of new jaundice after drinking daily large amounts of alcohol for, say, 1 to 2 years, and they show up jaundiced and a bilirubin of 35 as a new presentation of liver disease. And so certainly you want to assess for the diagnosis of alcoholic hepatitis. But after that, I want to focus on, should these patients be treated and are they potential liver transplant candidates? And when I say treated, some of these patients are at high risk for death in the preceding 6 months. And there's data that, at least in the short term, corticosteroids may improve that mortality. Now, this has been a much debated topic in the setting of hepatology for the last 20 years at this point. But while I would say the pendulum has sort of swung back and forth, more recent data that is on a systematic review level would support the use of steroids as long as there are no contraindications to treatment for severe alcoholic hepatitis with a Maddrey discriminant function score of over 32. And that's a scoring system that you can look up in these patients that essentially incorporates their prothrombin time and bilirubin. You want to certainly obtain an abdominal ultrasound to exclude other causes of jaundice, such as extrahepatic cholestasis caused by an obstruction, such as a mass. Screen these patients for infection, chest x-ray, blood cultures, urine cultures, acidic fluid cultures, and cell counts as well. And then assessing contraindications to treatment. So uncontrolled GI bleeding, acute kidney injury with a creatinine over 2.5, an uncontrolled infection, a multi-organ failure, or shock. And if they are eligible for treatment on the left side, then starting prednisolone 40 milligrams daily or an equivalent Now, this says with or without IV N-acetylcysteine, but typically, and this is based on AASLD practice guidelines, typically these patients just receive prednisolone and focus on an enteral nutrition goal of over 21 calories per kilogram. You want to use what's called the Lille model or Lille score, which is essentially a recalculation of that Maddrey's discriminant function 7 days after treatment. And there's even some data that you can calculate that 4 days after treatment to decide whether or not that patient should complete a 28-day course or not. If they do not respond to treatment, it would be appropriate to stop steroids at 7 days and either refer for an early liver transplantation or proceed with palliative care, depending on what is clinically appropriate. And so some nuances here. Well, what about the contraindications to steroids? This is a commonly asked question. And should these patients be considered for liver transplantation? So first of all, for steroids, so I mentioned infection as a contraindication. So we don't know, first of all, if empiric antibiotics in the absence of a confirmed infection improve outcomes in severe alcoholic hepatitis. And so there's no need to empirically give antibiotics. I'll get that out of the way first. Now, infections are common in alcoholic hepatitis, SBP, urinary tract infections, pneumonia, cellulitis. And so you do want to look for that. In addition, so regarding infection, if somebody has an uncontrolled infection in the setting of alcoholic hepatitis, we would advocate for not treating with corticosteroids. I recently encountered a case of a question of whether or not a patient should receive corticosteroids in the setting of COVID-19 infection that was minimally symptomatic without associated significant pneumonia. In that case, the patient did receive steroids and did fine. And so that might be an example where we can consider steroids. Regardless, if there's an uncontrolled severe infection, we would not use steroids. Those patients were excluded in all trials evaluating for corticosteroids in alcoholic hepatitis. Now, AKI, or acute kidney injury, has been an exclusion criterion in most alcoholic hepatitis clinical trials. So the evidence for steroids in patients with AKI is lacking. But if AKI can be resolved, then steroid treatment should be reconsidered. What about GI bleeding? Patients with GI bleeding have similarly been excluded in many clinical trials with alcoholic hepatitis. But actually, GI bleeding is not an absolute contraindication for steroids. So what we would say is if someone has controlled GI bleeding, so after control of GI bleeding, prednisolone can be given safely. And this is in the most recent AASLD practice guidelines as well. So should patients with alcoholic hepatitis be transplanted? This is obviously a controversial topic. This is this is somewhat contrary to longstanding dogma in transplant medicine that patients should be sober and away from alcohol for a significant amount of time before considering transplant. As time has gone on, we have gone away as transplant hepatologists from mandating a required period of sobriety. The old so-called 6-month rule was arbitrary and it was not really a rule. It was not a formal rule, but it's led a series of studies from now over 10 years ago led to increased awareness of outcomes related to alcoholic hepatitis and transplant. And actually, patient survival after transplant in patients with alcoholic hepatitis is quite good. Alcohol relapse after transplant is similar to the general population undergoing transplant for alcohol-related cirrhosis. And so these studies began in Europe and essentially were repeated and extended in the United States subsequently to support alcoholic hepatitis as an indication. And it is an indication. However, these patients need to be carefully selected. This is back from 2018 showing, this is from the American Consortium of Early Liver Transplantation for Alcoholic Hepatitis, or Accelerate AH. And you can see here, perhaps better than the previous graph, 1-year survival in these patients, 94%, 3-year survival, 85%. These are much higher than their, these are positive numbers compared to what their mortality risk would be. Their mortality without transplant is up to 70% at 6 months. Now, the sustained alcohol use after transplant is 10% at 1 year and 17% at 3 years. And some of you watching this might think, well, that's kind of high to have a patient transplanted for alcohol and have up to 2 out of 10 patients at 3 years returning to alcohol use, it underscores how significant of a disease alcohol use disorder is, how severe it is, and how hard it is to treat. And these are actually similar rates to patients transplanted for alcohol-related cirrhosis as well. I think that as time has gone on, we're supporting these patients better in terms of psychiatric care, counseling, both before and after transplant to hopefully improve on these outcomes, but it's not realistic, unfortunately, for those numbers to be zero. Now, this is an evolving background. The incidence of alcohol use disorder is rising. Small studies of carefully selected patients for transplant for alcoholic hepatitis have promising results. And like I said, a period of 6-month abstinence is arbitrary. It does not actually predict future sobriety. In fact, mandatory sobriety times encourage dishonesty, and patients have a high mortality risk within the 6-month period and may have benefited from transplant. So that I'm certainly not considering, or I'm certainly not making the point that all patients with alcoholic hepatitis should be transplanted. Even in the initial landmark studies in France, only 4% of all the patients at all the centers with alcoholic hepatitis ultimately received a transplant in those famous initial studies on this topic. And so it's still rare, but there are select patients to consider. And so these are patients for alcoholic hepatitis specifically. I'm excluding alcohol cirrhosis. Patients should be medically or steroid refractory. Okay, so they were severe on presentation with a high discriminant function. They did not respond to steroids. Certainly, candidates must admit to a significant alcohol use. And so patients denying alcohol use either are in denial or they don't have alcoholic hepatitis, obviously. And importantly, can the patient engage in the process? We would not want a patient to be so sick that they're on dialysis or impending dialysis, is stuck in the hospital to be considered for transplant. We typically would exclude grade 3 or 4 encephalopathy because that patient can't interact meaningfully with the transplant team. And these patients ideally should be able to commit to engaging in some form of rehab or counseling, intensive counseling therapy prior to or immediately after transplant. And so protective factors, so certainly insight for these patients is important. Perception of the negative consequences of alcohol use, social support. Negative factors would be psychiatric disorders, including psychotic disorders, personality disorders, repeated attempts at rehab in the past, despite, and then returning to drinking alcohol despite those attempts at rehab, and social isolation with lack of social support. Those would be negative prognostic values and may result in the patient not being carefully selected for transplant. We also use a phosphatidylethanol test or PEth test to aid in diagnosis and monitoring of these patients as well. It's a phospholipid formed by the reaction of phosphatidylcholine with ethanol, catalyzed by phospholipase D in the erythrocyte cell membrane or red cell membrane. Now, you certainly don't have to remember all of that, but just know that it's got a half-life of approximately 10 to 14 days and is a breakdown product of alcohol. So it's going to sit around in your bloodstream for several weeks, not influenced by age, BMI, sex, kidney disease, or type of liver disease. And it has high sensitivity and specificity when using a cutoff of 20 for alcohol use, moderate alcohol use in the preceding at least 4 to 8 weeks. So the American Society of Addiction Medicine and American Psychiatric Association suggest the use of biomarkers such as the PEth test as an aid to diagnosis, to support recovery, and as well as catalysts for discussion with the patients. Certainly is not to be used as a tool to catch or punish patients. That's certainly going to affect the rapport and the overall goal of helping patients with severe alcohol use disorder. And it's important to discuss biomarker use with patients before testing in order to maintain that therapeutic alliance and to improve alcohol use disclosure. I would not advocate for checking a PEth test without letting a patient know that you're ordering the test. And so referral considerations for alcohol use. Well, there's no 6-month rule, but patients certainly do have to demonstrate insight and commitment to abstinence along with social support. Those are absolutely critical in order for us, certainly as a transplant center, to consider transplant for these patients. And the patient can't be so sick that they can't engage with our psychosocial team. Hepatic encephalopathy. These are our conclusions today. Appreciate you all listening. I'll leave time for questions here in a moment. The conclusions for what we talked about today. Hepatic encephalopathy manifests across a clinical spectrum. Ammonia is implicated in the pathophysiology, as we discussed, but checking serum ammonia levels is of limited benefit, and I would not advocate for doing that in patients with chronic liver disease. There's also no data-supported cutoff of coagulation parameters prior to paracentesis, and so being told to lower the INR for a procedure is not supported by evidence and should require a conversation with you and whoever is asking for the cutoff regarding what would be appropriate in that setting. A critical recommendation for the management of the frail cirrhotic patient is protein intake of 1.2 to 1.5 grams per kilogram per day. And liver transplant can be considered for carefully selected patients with severe alcoholic hepatitis. I would just like to close by acknowledging our entire University of Colorado liver transplant team, including our nurses and coordinators, our transplant hepatologists listed here. And I'd also like to acknowledge Lindsay Carter, who's helped with our presentation today, Christy Click, our CME office and their IT department, as well as our current division director, Dr. Ed Mundowitz, Dr. Elizabeth Pomfret, our chief of the Division of Transplant Surgery, and John Gutowski, our executive director of Transplant Services. You know, we're a large team here at the University of Colorado, and I'd just like to acknowledge all of the people on the slide for their support and mentorship. This is our contact information for those of you in the area who ever need to get a hold of us. That's our phone number. We have a 24/7 attending hepatologist. I've included the phone and fax numbers for clinic referrals, as well as my own personal cell phone and email address if you'd like to get a hold of me directly. I'll just use this moment here too to mention that we do quite a bit of clinical outreach. I'm our director of liver transplant outreach and strategic development at our transplant center. And I travel to New Mexico twice a month, as well as Montana quarterly, and some other sites as well, to do clinical outreach in other states to expand access to care for patients in areas where there is not a practicing transplant hepatologist. Leave time for questions, and I really appreciate all of you listening today and your attention. Thank you very much. So what I'm going to do right now is I'm going to stop sharing my screen so that I can see all the questions in the chat. Actually, before I stop sharing my screen, I'll just throw this back up here real quick. So this was our webinar series that we did this year. And while I'm going over this in the final 3 or 4 minutes of the talk, please put out any questions you have in the chat. But we did these hepatology and liver transplantation webinars this year through the University of Colorado School of Medicine. Those were the topics that we did. We did liver transplantation before, during, and after. My colleague, Dr. Whelan, did a talk on non-alcoholic fatty liver disease. Back in July, we talked about viral hepatitis, and today, kind of a potpourri of management of various hepatic decompensations. Now, all of these topics provide free CME and ABIM maintenance of certification contact hours and are available on the website. The videos are also there, so you can go back and watch those. We'll be releasing the dates and topics for the webinar series next year. We'll have at least 4 talks during calendar year 2023 as well, including a talk on living donor liver transplantation, a talk on portal hypertensive bleeding. We're also going to have a talk on the management of alcohol use disorders as well. So some common and exciting topics coming up for 2023. So with that, I'll stop sharing. I'll take a look at the chat. Now, any questions, feel free to put them in there. I don't see any. Okay, everything was crystal clear. Oh, there is one in the Q&A box. There we go. So the question is, can you briefly discuss the utility of lactulose in the setting of acute liver failure, hepatic encephalopathy? Yeah, so great question. So I talked earlier about in the setting of acute liver failure, checking a serum ammonia level provides some prognostic value in terms of risk of cerebral edema, which is important in terms of management of those patients who are being considered for liver transplantation. There's actually no benefit there's no data that supports the benefit actually of lactulose in that setting. The key is controlling or minimizing additional risks for cerebral edema. So sometimes these patients, so certainly evaluating for infection, we keep the head of the bed up, frequent monitoring of the neurologic function. These patients are often getting frequent head CTs, controlling of serum sodium levels, mannitol sometimes in those patients, but there's no benefit of lactulose in controlling the encephalopathy per se. Those patients are also often being considered for liver transplantation, and the use of lactulose causes significant bowel distension that can complicate the transplant surgery itself. And so we try to avoid lactulose in that setting for all of those reasons. Okay. All right, well, it's 1 o'clock Mountain Time. And I really appreciate all of your attention today, and in terms of logging on and listening to this webinar. Again, the video is going to be saved on the website, as well as the information there for CME, which Lindsay also put in the chat. Please feel free to reach out to me or any of my colleagues anytime, and we're happy to help with any of your patients. And thank you again. Hope you have a great rest of your day, and thanks again.